My name is Dr. Kirsten Bond, and I'm a pediatric emergency medicine fellow at Children's Hospital of Michigan. Today, I'll be presenting our quality improvement project titled A Novel Approach to Enhancing Hospital Disaster Preparedness, the Disaster Roll Call. Disasters are unpredictable but inevitable. A school shooting, a highway pileup, a fire at a stadium. In a mass casualty event, dozens of patients may arrive within minutes, overwhelming even the most prepared hospitals. These moments are high risk and high pressure. Delays in communication, disorganized roles, or missing equipment can mean the difference between life and death. That's why regulatory agencies like the Centers for Medicare and Medicaid Services and the Joint Commission require hospitals to test their emergency response plans twice a year, including at least one full-scale drill. But there's a problem. Traditional full-scale drills are resource-intensive and often disrupt clinical operations for hours. They can take months to plan, and because they happen so infrequently, the knowledge gains rarely stick among frontline staff. Time and time again, we saw that during these full-scale drills, even when staff had been trained, the initial moments of activation were disorganized and chaotic. The very phase when clarity and speed matter most. To fill the gap between regulation and real-world readiness, our team created the concept of the disaster roll call. The disaster roll call is a no-notice, in situ, time-limited drill. It simulates just the first several minutes of a disaster activation, allowing staff to build muscle memory without significantly interrupting patient care. These drills are not intended to replace required full-scale drills, but rather supplement a hospital's existing preparedness plan. Our hypothesis was regularly practicing the first 10 to 15 minutes of disaster response would improve the efficiency, clarity, and coordination of hospital teams during the critical early phase of an event. Ultimately, the goal was to improve early disaster response, leading to improved efficiency and improved quality of care during a disaster event. This was a prospective quality improvement project conducted at Children's Hospital of Michigan. We divided the project into two phases. Phase 1 involved only emergency department staff. In Phase 2, with the approval from hospital leadership, we expanded to conduct disaster roll calls with the entire hospital responding as if it were a real event. Each drill occurred without any prior notice given to staff. A study facilitator would call the emergency department charge nurse and report a fictional mass casualty event in the community. This initiated the emergency department's internal disaster protocols. Drills lasted around 15 minutes and were observed in real time using a standardized checklist. The project was conducted in two distinct phases. In Phase 1, we focused exclusively on the emergency department. Over 6 months, we conducted several unannounced drills, each triggered by a phone call simulating a mass casualty incident. Observers tracked task completion and collected feedback, which informed changes between drills. In Phase 2, the project was expanded hospital-wide. We formally tracked 8 key departments and worked with every department to develop department-specific disaster response protocols. This ensured every team knew exactly how to respond and what their role was during the initial phase of activation. In addition to the 8 key departments like surgery, anesthesia, ICU, and inpatient nursing, we also had several other departments respond, including EVS, child life, social work, radiology, among others. Drills were announced using both the hospital's overhead paging system and the tenant alert system. Observers documented both task completion and departmental response, and feedback continued to guide system-level improvements. We identified 11 critical tasks necessary for successful disaster activation. These included everything from notifying key departments and retrieving communication equipment to assigning roles, securing supplies, and clearing space for incoming patients. Our primary metrics were time to task completion for certain critical tasks and overall task completion rates. In Phase 2, we also tracked departmental response rates of 8 key departments. In both phases, we used a structured 5-question survey to rate communication, leadership, and overall organization. Observers also provided open-ended feedback after each drill, which was then used to drive improvements through both phases. During Phase 1, we conducted 7 drills with emergency department staff. The average drill took 10 minutes, and completion of the 11 critical tasks was high, with 3 drills achieving 100% and the others close behind at 91%. Early challenges included delays in assigning roles and retrieving key equipment. On the observer surveys, leadership was rated 1.46, communication at 1.2, and overall organization 0.98 on a 0 to 2 scale. These results highlighted clear opportunities for targeted improvement going into Phase 2. In Phase 2, we expanded to hospital-wide drills. The average drill lasted just under 12 minutes. Our first hospital-wide drill had an 83% task completion, but the next 2 achieved 100%. We tracked responses across 8 departments, 4 of which responded to every drill, and the other 4 had a combined response rate of 87%. Post-drill surveys showed clear improvements in perceived leadership, communication, and organization, with communication scores rising from 1.2 to 1.83 and organization improving from 0.98 to 1.72. Across both phases, we saw consistent improvements in efficiency. Time to announce a drill improved slightly, while tasks like walkie-talkie and disaster equipment retrieval improved by about 25%. Overall, we reduced the average time to readiness by about 2.5 minutes, a 25% improvement. That's a significant gain in a high-stakes situation where every second counts. Beyond individual drills, this project created institutional momentum. We worked with each department to create customized disaster protocols, and we developed role-specific checklists for physicians and nurses to streamline task initiation. Feedback from each drill was shared during our disaster committee meetings, and the value of these exercises was quickly recognized. We observed a clear shift in institutional culture. Despite the frequency of these drills, hospital staff consistently responded to each activation, reflecting increased engagement, shared accountability, and a strong commitment to hospital readiness, a true institutional culture shift. This project demonstrated that the disaster roll call is a practical, efficient, and scalable method to improve disaster readiness. By focusing on the first 15 minutes, the time when confusion often peaks, we were able to improve task execution, interdepartmental coordination, and perceived communication and leadership. These improvements are supported by observational data, structured surveys, and the continued support of hospital leadership. We're now continuing these drills every other month and using ongoing feedback to refine our checklists and protocols. Our next goal is to assess whether regular practice leads to measurable improvements in full-scale mass casualty drills. Ultimately, we believe this model can serve as a best practice for other hospitals, especially pediatric institutions, looking for scalable, low-disruption ways to enhance their disaster preparedness and improve patient safety. Thank you for your time in listening to this project. I hope it helped highlight the importance of hospital readiness, especially when every second matters.